I call these guys surfer dudes, is what I call them. So they're up here just watching the waves. And with a synchronized cardioversion, what we're going to try to do is we're going to add to the patient's energy. And we want to add to the patient's energy so that it completes the cycle. So it'll complete the cycle. So what we're going to do is, as the energy is flowing through the heart, we're going to send energy with our machine that comes right behind it. It's almost like a sequential, like we talked about, dual sequential. So I'm going to come right behind the patient's energy, and we just want to push that all the way through the heart so that it completely depolarizes the heart and it basically resets is what we're after. So the energy setting on this is going to be typically lower. And again, so I'm going to come down here, I hit my energy setting, and usually it is lower. And when I say lower, like in the adult range, a lot of times it's 50 joules is a lot of times where we'll start. Or if it's pediatric, it could be 0.5 to 1 joule per kilo. So a lot lower setting that we're going to be using. So we'll dial that in, and then we're going to hit charge. Now remember, this patient is kind of conscious and kind of talking about it, and they're going to be a little worried about what we're doing here. So we're going to charge it up and make sure everybody is clear, and then just patient, this is just going to hurt. So here we go. Boom. Right, we hit the button, and hopefully what happens is that they convert out of that and that they'll go into a more stable rhythm, right? So I converted out of that into a more stable rhythm. Now, where are we? Okay, so this freaks some people out because I got all this stuff up here on the screen, and I need to see how my patient is doing. So I could hit the home button, which is going to take me back home. Gets me back here in my home screen, cycle my blood pressure again. Here we see that we're at 100/74. SpO2 is now jumped up to 98%, and hopefully my patient is more alert in all of this. Last guy I did this to screamed, and he told me that he said, I don't care what you do, but you're not going to do that again. I said, well, if you don't die anymore, I won't do that anymore. So we had a deal, and we got along really well. So that's synchronized cardioversion. So that would be for a super accelerated SVT with severe symptoms, or VTAC with a pulse. So we got VTAC with the pulse, but yet they've got symptoms, but they're still awake. They're not like, in cardiac arrest yet. So we would see those cases where we do either one of those. All right, so let's go the other extreme where we were talking about needing to pace someone. And I don't see one programmed in. That's fine. We'll make it happen. All right, so let's do this. We'll go back here. Let me just do a real quick manual, and bam, here we go. All right, so let me reset back to where we were. All right, so here we are looking at our patient, and we can definitely see that we've got some problems. And so let's say this patient is, obviously we got bradycardia, and they are in fact symptomatic. So they're having issues with this. So what would we do? So again, I've got to have the electrodes on the patient, and we've got to have the pads on. Now, the Zoll is one of these that is weird. If you will look at the Zoll packaging, depending on the type of pads you're using, but I've encountered this a lot, there is a set of pads that the pacing configuration is one way, but the defibrillation configuration is one way, because they have like a triangle pad and a heart pad, or a square pad and a circle pad, and it goes one way for defib and opposite for pacing. All right, and a lot of times even the preferential is what they call apex, so the pacing is directly over the heart and directly over the back. This is why you've got to know your machines. So what machine am I using? How is it supposed to be configured? How do I know? I mean, there's an instruction book. It actually came with one. There should be training on the machine, but a lot of times the information is on the packages. It's on the pads and stuff like that. So make sure we get those in the proper position. And I'm going to switch this over. So if I was in lead 2 mode like I would be normally, I want to switch my lead. I want to go into pads. So I'm ready here to actually be able to pace this patient. And again, this patient is conscious. This is not going to be painful. It's just not going to feel very well at all. So that could be a problem. I think my camera moved. Let's move it back. Whoa, turned it. There we go. All right. So that's just going to be a little uncomfortable. So first thing we're going to do is activate the pacer function. So I come right here where it says pacer. I'm going to activate this function, and I get a lot of options up here. My first option that I see is demand. So I see that's my first one up there when I have to get up here to use that. And I notice I can do demand or fixed. So here's my mode over here, and I can do demand or fixed. What is the difference? Just a little pacer discussion. So demand is the machine is going to work as an external pacer until the natural heart rhythm meets my criteria. And if the natural heart rhythm meets my criteria, then this external pacemaker will automatically go into standby mode. It doesn't turn off, it goes into standby mode, and it monitors the patient. If the patient drops below my program criteria, then it reactivates, goes right back into pacing function. All right. Fixed, if I'd put it in fixed mode, what that is going to do is it is going to be active all the time. It does not matter what the patient's natural heart rate is. It's going to work. Okay, so most of the time, just about all the time, we want to put it in demand mode. So that's why it was defaulted to that. So we'll just leave it there. Next one, I come down to rate. So I hit my down, come to rate program. And what rate would I like to have? All right, what rate would I like to have? Let's say this is an adult patient. I'm a big fan of 80. Okay, that sounds great. You want to even better? Let's do 85, 84. Let's do 90. I mean, let's just be aggressive. A lot of protocols are somewhere about 70, 80 range is kind of where where do we want to be. All right. The next thing I'll do is hit accept. I'm going to come down, and I've got output, start, and off. I actually am ready to activate my pacer. Even though I want output at 0, I'm going to go ahead and hit start. So my pacer is now active. Now, notice what happened up here in this squiggly line area. All right. Here, let me turn this off. Let me give you just a quick cardiology 101 in a nutshell. Notice that right now in our patient, it tried to speed up on me. Let's go back. Okay, so right now I've got a slow heart rate, which was at 40, and I've got a atrial depolarization wave. I've got a ventricular depolarization wave, and I got a ventricular recharge. It's going to be simple terminology. The depolarization wave is pointing up. That tells me that my pacemaker in control is above the AV node. That's what that tells me. It's pointing up. It's above the AV node. We'll see it kind of straddle the fence. It probably is the AV node. And when it goes to a negative deflection, we have a ventricular pacemaker. Now, why am I telling you that? Watch what happens when I turn it on. I turn it on. What happened? It started going down. Started going down because the external pacer that we're using is affecting the ventricles. So we've gained ventricular control of this heart rhythm. Now, what we have is these little spiky things right here. There's one, there's one, there's one, there's one, there's one, there's one. That is my pacemaker firing at 80 beats a minute. All right, that's my pacemaker firing at 80 beats a minute. However, I noticed some of these are not causing a QRS complex, or actually it's an RS complex, but it's not causing a complex. So that tells me I don't have enough energy. And I know I don't because my output is still basically none. Okay? So I'm going to start turning that up until I have an adequate rhythm. I'm increasing the energy. The patient starts to twitch a little bit. And boom, what just happened here? Look at this. Now, everywhere I see the little spike, I get a corresponding RS wave, is what I get. That is what we call electrical capture. So I have electrically captured the heart. Now, the question is, what is my rate? So now that I've electrically captured the heart, right, and so what it should be is we should rise. And here we go. Okay, we're at 78. I'm set at 80. There we go. We're getting there. All right, it's building on up, and we're getting where we need to be. This is electrical capture. Now, the next question is, do I have mechanical capture? So even though I've got energy flowing through the heart 80 beats a minute, do I have a pulse rate of 80 beats a minute? So you're going to feel of a pulse. And if I have those, I have successfully captured control of this heart. So I have electrical capture and mechanical capture. Now, what I like to do is play with it a little bit just because I get bored real easy, I guess. So here we are at 30 milliamps of output. Let me lower this energy setting and see what happens. So we'll go up here, energy lower, and I lose capture. So we don't want to do that. 25 is a loss. We'll go up. 30 is where we were. We was happy. I'm going to go up to 35. I'm going to hold right there. So what I like to do is finesse mine because a lot of times, to be real, when you're setting this up, this is probably how most of you do it. You're at 0. You don't have capture. You're like, oh, my goodness, oh, my goodness, oh, my goodness. And boom, we've got it. Well, notice I'm at 60, and the patient's twitching like crazy. So let's back that down and find the sweet spot. Now that we grabbed hold of the heart, we find the sweet spot, and we find where we lose it. There we are, we lost it. We go up to where we have it, and I like to add 5 more just as a little threshold tolerance. Some patients over time, as you're pacing them, they may close off to the energy, so you may have to go up. Some patients may open up to the energy, so you can actually come down. Now, remember the protocol said consider pain management. You're shocking the heart, but this just feels like a TENS unit that your unfavorite friend turned up really, really high. That's kind of what it feels like. And so it gets annoying and uncomfortable. So you might want to consider some pain management for that, but be careful because what happens if we enter into a sedation range and we start knocking the patient out? You remember, you're artificially supporting them here. You don't want to create another problem. So we want just enough to kind of tolerate that. You're not going to eliminate it. You're not going to make it comfortable. You can just make it a little bit less annoying. And so that may be what you'd want to consider. All right, so that is the pacing discussion, synchronized cardio version. Any questions on the defib functions, pacing functions, anything like that on the monitor? Anything, just throw it in the question box. If y'all want to talk to me, you can hit the little raise hand icon, and we'll figure out how to drive it from this screen. I don't know. Okay? Not seeing any. Okay, no questions, no hands. All right, so let's do the last thing. Let's throw in the hand-heavy cheat method for pediatric calculations. This even kind of like knock us out a little bit early for the next session too, because we got a continuation of pediatric resuscitation there. But the hand-heavy method is from Dr. Hand-Heavy, and he puts hand in there. His name is Dr. Antevy. I'm sorry, Antevy. And he puts hand in his stuff because he developed a little cheat method that uses the hand. And so you'll see some providers out there kind of counting. and doing things like this. And I'm holding my hand up so my camera's reprogramming, so maybe it won't move. Okay, so they'll hold their hand up, and what this means is this would be a 1-year-old, 3-year-old, 5-year-old, 7-year-old, and a 9-year-old. So 1, 3, 5, 7, 9. That's kind of how that would work. Okay. Now, and the reason this is advantageous, sometimes it's easier to guess a pediatric's age than it is their weight, right? So if you can get their weight, you can do the measuring tape, that is great. But if they're beyond the measuring tape, because we're talking about kids beyond the measuring tape, you can guess their age, right? So that'll be 1, 3, 5, 7, or 9. That'll be the age. And when guessing their weight, that goes to 10 kilos, 15 kilos, 20 kilos, 25 kilos, and 30 kilos. Right? So that's all you got to do is, so if they are a 3-year-old, right? So if that's 1, 3, that's 10, 15 kilos, right? If they're, 9 years old, so that's 1, 3, 5, 7, 9. So that's 10, 15, 20, 25, 30 kilos. So that is a way of kind of just guessing a weight measurement in these kids uh, and getting that figured out. Okay. Oh my goodness. All right. So let me throw you some questions. Got any questions in there for me? My voice is going. We're sitting right at 9 o'clock, almost 9 o'clock anyway. So that's okay. And we did great on time. So if y'all got any questions, feel free, put them in there. Any comments, put them in the question box as we kind of wrap up tonight. Hopefully you got something good out of tonight. I hope it wasn't just a whole lot of just drumming on, but that gave us an opportunity to really walk through the protocol and look at it from a protocol perspective. And we'll do that for some of the other stuff too that's coming up. Next class is going to be a Tuesday. It's going to be next Tuesday, October the 21st. We're going to go over CNS injury. We're going to talk about acute coronary syndromes and chest pain. And we've got pediatric resuscitation review also scheduled that night. But I think what I'm going to do is I'll work something else in there, give you a little unique treat and a little bit of a personal journey story for that one. So that'll be exciting to kind of come back for that one. And that's where we'll be. So that'll be next Tuesday on the 21st. I'll be doing another double header that day, so I hope my voice holds out until 10 o'clock at night. If you don't have any other comments, any other questions, you are free to go.